Kuksa. Liga Kuksa is currently the head of the multi-drug resistant tuberculosis department at the Tuberculosis and Lung Disease Clinic at Riga East University Hospital in Riga, Latvia. Dr. Kuksa received her MD in 1995 from the Medical Academy of Latvia and specialized in pulmonology in 1998. She has been involved in the World Health Organization Collaborating Center for Research and Training in Management of MDR-TB's training activities since 2000, and has also worked as the WHO's MDR-TB consultant in Russia and other post-Soviet countries. Dr. Kuksha's main scientific interests focus on multi-drug and extensively drug-resistant tuberculosis. Dr. Kuksha is a member of the European Respiratory Society, the International Union Against Tuberculosis and Lung Disease, and the Association of Latvian Pulmonologists. And I will turn you over now to Dr. Kuksha. Thank you.
Thank you for introduction, and good morning and good afternoon for everybody who joined this nice kind of activity. This is my first experience with a webinar, and as usually it's a little bit nervous, but I will try to explain our experience with Bedaquiline and his role in our program. And always I would like to start with this slide, despite that you even can see Latvia involved map. The Latvia has approximately 2 million population based on last census in 2011, and Latvia also, since independence and beginning of 90s, has a huge problem with tuberculosis outbreak, but despite to that, we have a lot of achievement during these last 15-20 years. And describing current situation with MDR-TB, that from the first graph you can see that there is no graphs coming. But anyway, registered new TB cases and MDR-TB cases in Latvia are decreasing, and also this shows improvement since 1998, where was the highest point of incidence in Latvia, and after implementation of DOTS in 1995 and also implementation in MDR-TB treatment program, we achieve that our amount of MDR-TB patient decrease for more than 4 times, and proportion of MDR-TB among new and retreatment cases decreased in the last year, in the first years in retreatment group of the patients, and not changing in the last years. But we still ranks among 27 high burden MDR-TB XDR-TB countries in the world. And if you look at the something happened with slides, and we can see the graphs, but in the structure of the MDR-TB tuberculosis, that we see that despite the number of MDR-TB is decreasing, the proportion of XDR-TB cases is rising last years, and in 2013 a proportion of XDR-TB patients among MDRs was 18%, and also HIV positive patients in this last year was 20% among MDR-TB patients, meaning that each fifth patient, MDR-TB patient, has HIV infection or could have extensively drug-resistant tuberculosis. Looking at our results and recently published our analysis where we looked at the trends, characteristics and treatment outcomes in Latvia during 11 years, we see that our treatment result, we could achieve 50% treatment successful treatment result. And also in this MDR-TB group, comparing with XDR-TB group, in XDR-TB group there is a much higher failure rate than in MDR-TB group, and it makes us think that we extremely need new approaches and new drugs for MDR-TB patient treatment. But there is no included such analysis. But when we look at the years after 2006, TB medication as linezolid and also later imipenem, cilastatin or other carbapenems, that we can achieve in this XDR-TB group almost 60% of cure rate. That overall in the Latvia a little bit described how we look like and how we perform our program. That since 2000 all registered TB cases undergo culturing, and all positive cultures undergo DST against first-line medications. And if isoniazid rifampicin resistance is assessed, then cultures are assessed for second-line drug susceptibility tests, and DST is centralized. Since 2004, we introduced also line probe assay, and this result is used to modify treatment, especially in cases we do not rely on phenotypical results or there is any other technical problems with microbiology results. Since 2010, expert MTB RIF has also been used in Latvia, and empirical second-line treatment is started immediately after receipt of rifampicin resistance. And how we manage multi-drug extensively drug-resistant tuberculosis cases. All patients are managed under expert consilium. Hospitalization, or meaning duration of hospitalization, depend on smear and culture conversion and tolerance to medications, and also social factors. Is possible to how we can organize DOT for the patients, then patients remain in hospital sometimes for the whole treatment course. All drugs are given daily by direct observation for entire duration of treatment. In hospital, this administration is daily. In outpatient, depending again on distance to medical facility or to patient's drug tolerance or on the expert consilium, it could be 7, 6 or 5 times a week. Then responsibilities of consilium is not only to prescribe appropriate regimen for MDR-XDR-TB patients, but also provide all necessary adjustments every 3 months. And also this is kind like of supervision. We also monitor treatment effectiveness and look after adherence to the treatment. During those expert consiliums, we also define treatment outcomes for the patient. Especially we discuss when to stop treatment and decide is it failure case or not, or how to organize further treatment for this patient. We also decide which cases we have to discuss, we have to add for surgical, adjuvant surgical treatment. Only then we go to the surgeons and ask for the surgery. And also we decide duration of treatment course. Regarding the trials, the the year 2008 was quite tough for the Latvia program because both trials, OPC and TMC, arrived almost simultaneously in 2008, and we have or had only one trial site. In trial C208, we enrolled 13 patients, and it seems not too much as we probably would could have enroll, but had to be smear positive. But we enrollment in the trial based only on BACTEC result, meaning that patient before received first line medications. We all know, especially in cases when patient has has sensitivity to pyrazinamide and ethambutol, they could convert even during first 2-3 weeks. But the trial brings a lot of new knowledge for us and how to deal with informed consent. We learn a lot and also use later those skills in compassionate use program. For trial 209, again the same amount of patients, 13 patients, and there was again the another opportunities. And first of all, that you couldn't see from the slides, but I explained that the amount of MDR-TB cases is decreasing. This amount is decreasing every year, and at that moment when we start trial C209, there was really difficult to find patients who comply with inclusion criteria for two simultaneously happen trials. But again, I could say that we learn a lot and use later this experience. A compassionate use program. Why? After trials, we understand that we have a growing group of the patient with extensively drug resistance and for whom there is no possibility to prescribe regimen with at least 4 or 5 effective medications. And in the summer 2012, we started negotiation with Latvian State Agency of Medicine for Bedaquiline Compassionate Use Program. We had 2 attempts to apply all necessary documents to this agency, and finally in January 2013 we received approval for the first 5 patients, and first patient was enrolled in February 2013. To the date, we have enrolled 35 patients in the compassionate use program, 2 of them only this year, and last patient we enrolled on 16 of April this year. And currently on Bedaquiline are only 5 patients. Decision to include patient in compassionate use program basically I could say are based on drug sensitivity tests. Those patients, almost for all patients, we have gene expert tests. And if there is rifampicin resistance in gene expert test, then microbiology lab do drug sensitivity test on BACTEC for such cases for first and second line drugs. And meaning that during the 3-5 weeks we received all first line drug sensitivity data and crucial second line medication as amikacin, capreomycin and ofloxacin. And straight after that, for those who have quinolone resistance or quinolone resistance and injectable resistance, we discuss about possibility to include bedaquiline or delaminid in treatment regimen. When we started compassionate use program, that we have a group of patients that there was no possibility to achieve sputum and culture conversion, This is one reason why we started bedaquiline, or there was evident that we have to do adjuvant surgery, but after surgery we had to strengthen treatment regimen using bedaquiline. Regarding informed consent, at beginning and now in compassionate use program, we use translated from the English to Latvian form, which is made in compassionate use program. But most important is introduce patient with the program with the benefit and also all risks and other problems before we send application to compassionate use program to avoid such a thing that we apply for medication, receive medication, but later patient refuse participate. After this and for the next step, as we received approval for our government to that we will have money to buy new medications for more than 15 patients, then we developed our own version, which is a little bit in simple language in Latvian and Russian versions, because we have both groups of patients. We include main information in those consents, and also include all patient responsibilities, and also include part in this consent regarding that we would like to collect and analyze afterwards all data received during the this medication use. But I agree with Jennifer from the previous webinar that informed consent is not lonely list, and we have to be able to explain indications for the program is as you probably may have seen, documented pre or XDR-TB older than 18 years, and what we add that background regimen could consist of all probably effective second line medication and at least three new repurposed or never used medications, including bedaquiline. And regarding contraindications, I'm not going to call all those contraindications, but generally I could say that we have to check all the problems before we start bedaquiline in the treatment. But I could add that we had no huge problem with lab abnormalities at beginning of the compassionate use program, meaning that we had no cases when due to those abnormalities we have no possibility to start a compassionate use program. And also we have no patients with history of long QT syndrome, and at the beginning there was no cases with prolonged QT interval more than allowed. We send more applications than 35. Actually, we send 37 applications to compassionate use program, and 2 of them were rejected, and 1 patient was with no pre or XDR-TB but really poor tolerance of several second line medication. From moxifloxacin she had axial tendinitis, From proteonomide, there was nausea and vomiting. From terazidone, anxiety and depression. And from amikacin, tinnitus. And there was really desperate tryings to find the best treatment regimen for this patient. And finally, we apply for the Bedaquiline Compassionate Use and succeed. And currently, patient is completed treatment as cured. Second case was with phenotypically sensitive rifampicin, but from the molecular test we see that there is a resistance, and you see in this slide, try to open pointer. Yeah, there is that we see that on liquid media rifampicin, sorry for Latvian, but it means that there is a sensitivity to rifampicin. And looking at the other medication resistance, that we see that there is a huge resistance, only rifampicin, terazidone, and some other second line drugs are sensitive. And then we provide line probe assay and also gene expert from the same sample as was done for Bactec, and we saw that there is MTB DNA in the sample with rifampicin resistance. This is this test result, and also in a line probe assay there was found mutations in RPOB gene and in this delta WT7, meaning that received treatment for more than 9 months, you see the huge cavity in right upper lobe in the X-ray and also in CT scan, and there was no possibility to achieve conversion for this patient, and this was the reason why we sent for bedaquiline this case. But again, it was rejected, and we add to treatment imipenem, linezolid, and also amoxicillin clavulanic acid. Patient underwent surgery and now is converted, but currently still on treatment. Regarding the drug sensitivity pattern among our 35 compassionate use program patients, you see the highest resistance is to pyrazinamide, then follow ethambutol, then moxifloxacin, then capreomycin, then proteonomide, and ofloxacin 69%. Quite a huge amount, but in the same time I could say that we have tested only 5 patients to linezolid, but all of them are sensitive. And also what we see that terazidone, it is our I think it's not only Latvian problem, that we see very low resistance to cycloserine. Relapse cases with extensively drug resistance, we only in some cases see resistance to cycloserine. It makes us think that we not always trust to this result, but despite that we use medication. And even we call pre-XDR XDR, this group is not very similar. And if you look at the different kind of resistance among this group, we see that we had patients resistant to all injectable, 9 patients resistant to all quinolones, but no resistance to injectables to 8 patients, and resistance to at least 1 injectable, at least 1 quinolone to 70 patients. But even if we have injectable resistance or quinolone resistance, it doesn't mean that all quinolones and all injectables are resistant, and I will show a little bit later in case presentation this. Drugs include in treatment regimen, and mostly treatment regimen consists of linezolid, teracidone, pyrazinamide, because we know synergism with bedaquiline. We try to include pyrazinamide in treatment regimen, at least for the time when patient receive bedaquiline, and if there is no serious side effects from pyrazinamide. The drug administration, and again, as the same as in probably all countries, 400 milligrams for the first 2 weeks, next 22 weeks 200 milligrams 3 times per week. Usually we do Monday, Wednesday and Friday. And after stable conversion, and there we mean culture conversion, treatment could be continued in outpatient setting. And how we deal with this monitoring of treatment effectiveness and a little bit supervising all this um, process. Then we ask patient visit us, our center, once a month, and patient usually come with all blood tests done before, and also with ECG if we and then we have possibility to measure QT interval and also ask regarding any compliance. And then we give new blister with bedaquiline, which patient brings to the DOT cabinet to responsible person who is responsible for DOT. This is treatment efficacy and also patient monitoring table, and there is I could say this is nothing new. We took this approach from the TMC 207 trial. Then there is all measures that we have to do in each time point, and those are our time points: day 0, day 4, day 7, second week, and then every month, first month, second, third, fourth, until the 6 months. And those are measurements which are always looked through for each patient. Regarding the registered side effects, receive bedaquiline, there is no adverse events registered for the 5 patients, adverse events not related to bedaquiline, and this is a decision made by treating physician. If there is no possibility to decide from which medication is adverse event, then we go together and then we decide is it bedaquiline or not. But again, we use previous trial experience and also the published data regarding bedaquiline side effects. And adverse events related to bedaquiline had 5 patients, not so many, but we had. During problem, we also counted how many adverse event episodes we had, and only one adverse episode during those 24 weeks we had for 17 patients. 8 patients had 2 episodes of adverse events, and 3 patients had more than 3 adverse events per this bedaquiline treatment time. Serious adverse events. We reported 3 serious adverse events: bradycardia for 1 patient. Later we solved this problem, but I could say it was the first our experience that this patient was the second patient which we enrolled in Bedaquiline Compassionate Use Program, and then we yeah, this is some kind of also learning process. But later we did Holter monitoring for patient, and there is no cardiac problem found. Um, Unfortunately, after 4 months of treatment with bedaquiline and 7 on MDR-TB, a treatment patient lost to follow-up, and then yeah, we don't know results, the further results. We have one death case during the um, how to say follow-up period. This patient died 2 months after completing bedaquiline. She was HIV infected patient with quite good CD4 count, if I could say so, 360. And this, the cause of death was Clostridium difficile colitis. And one toxic hepatitis also report. The treatment was stopped. All treatment was stopped, including bedaquiline, but later we were able to continue bedaquiline with slight tailorments in treatment regimen. And that we also calculate QT interval during the treatment, and at each point was done ECG, 12 lead, and this ECG was read by a certified doctor, and if there will be was more than 5 millisecond QT interval, then we repeat ECG, and but we had no any case with more than 500 milliseconds interval, and the calculation after doctors the result we calculate using application QX calculate to calculate this correction by Frederica. And yeah, and additionally from the analysis, and I somehow didn't put this analysis there, that only 9 patients were detected with rise more than 60 milliseconds, comparing with baseline QT during this treatment with bedaquiline. And for 5 patients we registered more than 450 milliseconds QT interval prolongation during the bedaquiline treatment. And culture conversion, we had at the beginning of bedaquiline we have only 6 smear positive patient, and 16 culture positive patient, and from those 16 patients 14 currently are completed bedaquiline, not completed bedaquiline, but are stably converted, culture converted, and the median culture conversion time is 26.5 days. Treatment outcome at the moment, we have 18 cured patients, 1 died, 1 lost to follow-up, and 15 continued treatment. And if we look only those who completed all treatment, not only bedaquiline, but they have treatment outcome, that like at the end of the program, but this moment is very promising result. Always is this the question how to decide, is it hospital or outpatient treatment? And again, main criteria are tolerance of medication in 1 dose. It's very crucial thing. Course of tuberculosis, is there any the exacerbation or other TB sites with problems or problematic underlying diseases, then those patients longer stay in hospital, and we later decide regarding outpatient treatment. And the also very crucial thing, compliance to the treatment. If we know previous experience with uncompliance, then we try to discuss with patient and to keep this patient in hospital treatment. But sometimes yeah, it's not very easy. And then I would like to show some cases why bedaquiline. And first cases actually regarding the why hospital treatment. This patient was firstly diagnosed in 1982. We do not know sensitivity data, but we know that patient received treatment with interruptions and probably was cured. In 1998 was detected relapse with pole resistance, and patient actually treatment interrupted. And next point was 2004 when was diagnosed MDR-TB. Again, patient had poor compliance due to alcohol abuse, and since 2005 he was on palliative care, and actually in a home setting, because he refused to admit palliative care hospital. In November 2013, he admitted the hospital due to heavy pulmonary bleeding and was smear positive. And at this point, he expressed a willingness to receive treatment for MDR-TB. TB. And when we look at the drug sensitivity tests, we see that how look like resistance pattern during those years. At beginning, uh, polyresistant with isoniazid streptomycin, later isoniazid ethambutol streptomycin, and since 2004 there is a multi-drug resistant tuberculosis. Actually, since 2004 he is extensively drug resistant TB patient. And it was clear that this patient we will try to keep on hospital treatment at least while patient received bedaquiline. But the second lesson learned for this patient is that it is very recommended that we have possibility to test all injectables and all quinolones which are in use in country, because when we look at this case, there is difference in injectables. You see that all injectables for this patient is sensitive comparing with previous episode. But what we see there, surprisingly, that levofloxacin is also sensitive, despite that ofloxacin and moxifloxacin is resistant for this patient. And we used levofloxacin for patient, and actually patient is stably converted achieved culture conversion, and now he is in outpatient setting. He is compliant and continue treatment. Yeah, and actually those things what we found. Second patient is HIV positive patient, HIV since 2000. Actually pre-XDR-TB relapse case, and you see that patient received treatment from 2011 to 2013. In February 2013 he was cured, and only after 3 months he admitted TB hospital with TB characteristical compliance, and we were very yeah, sure that it is TB relapse case. Also take in account that in 2013, while on MDR-TB treatment, patient interrupted antiretroviral treatment, and there was high suspicion of TB relapse. And from the X-ray, we saw that disseminated process in both lungs and in almost all parts, lobes in the lungs, and even with some miliarization signs. And we were very sure that we have to start treatment, especially taking into account that the patient is HIV infected with quite advanced current disease, but also it was evident that we have uh, to add to the treatment new medications, because if we compare drug sensitivity tests year 11 and year 2013, the only difference is capreomycin resistance, and we apply for compassionate use program, and we include in treatment regimen linezolid, imipenem, um, and also bedaquiline. And currently, I could add that patient is cured. He complete full treatment course, and one more lesson learned. Then you can see improvement if we compare May, where was relapse detected, and 5 months later, the X-ray show improvement. But for this patient, also for some other patients, there was new experience administration, and this patient received imipenem more than 1 year. And I always show him as an example, because with imipenem tolerance we have quite high problems. One adjuvant surgery case, patient with he has tuberculosis since 2008, again with quite poor compliance. Uh, treatment new treatment course was started in March 2013, and all this treatment he received in prison sector, and for this treatment was for 10 months, and patient was not converted, and on DST were clear extensively drug-resistant tuberculosis. Patient was released from the prison in January 2014, admitted our hospital, smear and culture positive, and we understand that we have to have adjuvant surgery for this patient, because this huge cavity in left upper lobe, and we apply for the Bedaquiline program, and patient underwent surgery in 13 March of 2014, and after 7 days we started Bedaquiline for this patient, and other medications. We tailored treatment regimen according to drug sensitivity tests, and actually we achieve conversion with surgery, if we could say so, because the last positive culture is from the surgery sample. And this patient, actually, again, I could say this is the challenging case. Patient was diagnosed in July 2014. She was investigated as a contact with MDR-TB patient, which is actually her son. And what we found in drug sensitivity tests, you see that starting from GeneXpert, which is rifampicin resistant, we see that patient has sensitivity to only linezolid, and we immediately apply for compassionate use program. We get a positive response from the compassionate use program, and started treatment. But then the next question is, we all know that we bedaquiline use only for 6 months, But in my opinion, in such cases as this case, we have to prolong duration of bedaquiline or decide altogether what to do with such cases, because patient received treatment since July. I hope that will open my since July, when in both upper lobes there was nodules and in right lobe was cavity. In October, she started bedaquiline, but if you look at the CT scan, there is still small cavity, and also in February this year there is still small cavity, and the patient uh, in January this year had positive culture. Only first negative culture we have from February this year. It means that since conversion, and there is evidence for such kind of patient we need bedaquiline or other new medication, delaminid for example, for more than 6 months to be sure for the result. And I came to my conclusions that our experience shows that treatment results improves to 90%, I hope, comparing with last published data from 2010. Tolerance to treatment regimen, including bedaquiline, overall is good. Of course, we have to monitor closely. We have to deal with side effects. We have to tailor treatment regimen, but I could say it is doable. QT interval prolongation is detected, but not to reach critical point of 500 milliseconds and not cause related side effects. And my conclusion is that for the TB previously, currently, and I think for the future, we have to have very good program with all programmatic parts in this, and that good programmatic conditions are crucial, because we have extremely good new medications, and we have no possibility to repeat previous mistakes or errors what we did with isoniazid and rifampicin, and that's my strong belief. And my acknowledgments goes to my colleagues in my MDR-TB ward, Linda Barkāne, Regīna Lazdine, to my boss, Andra Cīrula and Vaira Leimane, to microbiology lab, which is our best supporter and team member, to Katarina Krenzer, who helped us with statistical analysis, and Jennifer Furin, who enrolled me in Swift response project. Many thanks to all listeners, and I could say that we can do a lot by getting together, and I think the work with tuberculosis always is teamwork.
Thank you,
Yeah,
Lisa.
there
A few
is.
questions that came up.
Sorry,
So
I didn't hear.
I think we have about 10 minutes, so there are a few questions that came up, so feel free to address those as far as we can get.
Yeah, so then I have some questions. There is one question regarding forms. Would we will to share them? Of course, I will share them with you. I can also translate. You can write me email, and and the next question is, what dose of linezolid and clofazimine what doses of linezolid and clofazimine did you use? Actually, clofazimine we use only for one patient because it's not available and not even registered in Latvia. We can't include this in essential drug list. Our drug agency refused it, but for one patient we used it, and we start with 0.3 grams per day, and after months continue with 100 milligrams per day. Linezolid, at beginning we start, if patient is in good condition with no huge gastrointestinal problems, we start with 600 milligrams twice a day, and then after 2 weeks or 3 weeks continue with 600 milligrams per day as soon as patient tolerate. But I could say we use Pfizer linezolid, and patients tolerate well, and most of them use linezolid more than 1 year. Yeah. Serious adverse. The third question is, were the serious adverse events related to bedaquiline or to other drugs? It's quite difficult to say, but for those 3 cases, we think that those were related to bedaquiline. For the first, bradycardia, I could add that patient reported that he had bradycardia even before he started MDR-TB treatment. Then we could, this is a discutable question, but for those 3 reported, we could say yes, they were related to bedaquiline. The next question is, what were the main adverse events you saw in the 5 patients that had adverse related bedaquiline? Again, it is transaminase elevation of liver functional tests, ASAT, ALAT. There is, there is question what antiretroviral treatment we use for bedaquiline. We use only allowed treatment for compassionate use program, and this is a triple NRIT regimen. I could say. I could say we have experience only with 2 patients. Can you tell us a little bit about Latvia's plan to introduce bedaquiline programmatically in the country? Yes, we have plan. We also have political commitment, and we received extra money for bedaquiline. And I think that when we look at the guidelines bedaquiline, we comply for all necessary requirements for bedaquiline, and we are ready to start, and if I am correct, that next month we can start a electronical tender for the bedaquiline. And the last question is, did we see more adverse reactions on linezolid rather than on bedaquiline? My opinion is no, that we do not see. We even in this we have one ongoing retrospective analysis of linezolid use and the linezolid side effects, but my opinion is that there is no more side effects from linezolid than from bedaquiline, and we have some anemia cases and some polyneuropathy cases, but again, those patients usually are with some underlying comorbidities which worsen the tolerability of all other second line medication, including linezolid and bedaquiline. And
Thank you so much, Liga. Thank you so much,
yeah.
Dr. Kuksa, for a great presentation. I think